Director here with Shatterproof. Welcome to our webinar today on our Continuous Quality Learning Improvement Learning Series. I have about 102, so in the interest of time, we'll go ahead and get started. I did want to mention a couple of housekeeping items before I turn it over to our speakers today. First, please, as you join, mute yourself so we can be respectful of our speakers. Secondly, if you have a question during the webinar, feel free to leverage our chat feature. We will also have a formal Q&A at the end of the webinar as well. And also another quick reminder, we will have our materials presented in our recording available at our website for our CQI Learning Series, treatmentatlas.org/CQI. Also, be on the lookout for an evaluation of today's session. Will be sent out in the coming days, so I wanted to make you aware of that. At this time, I would like to introduce our speakers. First, we have Todd Molfenter from NIATx. Todd is the Executive Director at the NIATx Foundation, a firm dedicated to improvement of behavioral health services and outcomes. He is one of the founders of the NIATx Organizational Change Model and has over 20 years experience of leading national, state, and local quality improvement initiatives. So welcome, Todd. I would also briefly want to introduce Lisa Blanchard. Lisa is a Vice President of Clinical Services at Spectrum Health Services based in Massachusetts. Lisa is responsible for clinical design, clinical development, and training across Spectrum's programming. This includes 15 outpatient programs providing opioid treatment, substance use and mental health, court-mandated treatment, and 7 inpatient programs in 2 locations, including detoxification, clinical stabilization services, and residential treatment. Lisa has over 20 years of experience in behavioral health administration and is a behavioral health consultant and a national NIATx process improvement coach, and has served as a consultant and presenter both statewide and nationally. Lisa is also co-host of a podcast, Airing Addiction, and holds a master's degree in counseling psychology from Assumption College. Welcome, Lisa. At this point, I'd like to turn it over to Todd, Dr. Molfenter.
Okay, great. Thank you. Let me get my screen active here, and we will go ahead and get going with the presentation. Okay, super. Okay, share screen. Okay, great. Hello, everyone, and thank you for joining us today. And what I wanted to do today, or what Lisa and I want to do today, is talk about these shatterproof measures and how it just really creates an opportunity for quality improvement. We're going to talk about this primarily from an organizational perspective, but certainly this can be used in a variety of ways. And as we complete our conversation, if you're like, hey, it'd be really nice to know how to sort of apply this and other settings, other situations, certainly ask us about that. We would be more than happy to talk about that. But really today, talking about these shatterproof measures, which have been developed with a really an amazing and thorough process, and talk about just how those can be applied in an organizational setting to improve operations and improve services. And so I'm talking to you today from the NIATx Foundation. Quickly, the NIATx Foundation helps organizations and people simplify and improve treatment and recovery pathways by translating evidence into practice. Our background is we're health system engineers, and we just spend a lot of time trying to figure out and understand ways to improve services, and we'll talk about some of those today. Okay, so what really the conversation today is going to be about is, with shatterproof measures, with the state giving new policy directions, federal government giving new policy directions, different data coming at you, whether it's from payers or public health departments or Shatterproof. And then also you have these different tools and strategies you're using to make change. And really what we want to think about today is how to make it so these aren't sort of isolated events, and sort of bring them together into a system, a quality improvement system, and where you can sort of think through policy direction and create policy direction of your own, where you can receive data and sort of analyze and work with that data on your own as well. And then we're also going to talk about some tools and strategies as well to make, to make improvement and make things better. Okay, so within an organization, what we want you to think about, or what we find to be helpful, is rather than sort of having sort of, just sort of what I call opportunistic events, where it's like, oh, hey, we just heard from the state on this issue, or hey, did you see this data issue over here, or really we should do a project over there. You think in terms of having a system, and in the system you have some kind of quality oversight committee. And we'll talk about that a little bit here. You can have different names for it. You have quality improvement projects, but very importantly, you have a sort of a data approach to help guide what you're doing. So let's talk about that a little bit. First of all, with this quality oversight committee, a lot of people call them quality improvement committees, and really just ask yourselves, do we have a function like this? And really a lot of organizations do, a lot don't. And either way, I mean, if you don't have it, I'd suggest you work on putting one together. A lot of the quality oversight or quality improvement committees or what have you tend to be very focused on compliance. In other words, we're going to have the state's going to come in and give us a review, or, we're having, a payer wants to check on a certain issue, or we're having joint commission, we're having CARF, things like that. And really what we're encouraging is something more than that, something where you're really looking at what's happening within the organization and setting quality improvement priorities. And in the second half of our talk, Lisa from Spectrum Health Systems is going to sort of talk about how they have that structure, and so it'll give you sort of an idea of how it's applied. And really within that structure, you don't want to overdo it, but think in terms of having vertical and horizontal representation. In other words, not just have it to be a committee of primarily physicians and a few staff supports. Have it where it is sort of horizontal. If you have peer recovery folks in your organization, have some peer recovery folks involved, have some folks from the intake function and the like, where you're getting some broad representation around what you're doing. And also, if at all possible, if at all possible, somehow include patient and family perspectives. Again, it could be from peer recovery people, it could be from alumni, but we really find that when you have those folks in the room, even if it's one or two, it really, it just keeps you focused on sort of the end service that you're working on, and just keeps you focused on what you want to ultimately do is improve services. Okay. Beyond the quality improvement committee, because again we sort of talked about this group, the next thing we want to talk about is the role of data. And a lot of places have what's called a data dashboard, and really with this quality improvement committee to have some kind of data set you're working from. And this sort of two general issues around that. One is, what data do you have there? And there's literally, at one point we were working with an organization, and we were looking at all the different data that they had come in. And, from, accrediting organizations, from payers, from local health departments and the like. And we discovered 892 different data elements. And if you counted ones that were similar but different, it was over 1,000. And so you have to ask yourself, boy, Todd is suggesting we sort of have this data dashboard. What does that mean? And what it means is you want to sort of narrow down your data so it's something that's truly a dashboard. On your car, there's a lot of different instrument panels, but really you want something that's going to give you sort of some of the key pieces of information. How much gas do you have? How fast you're going? Things like that. And what's really nice about the Shatterproof measures is you had this group of people who, and if you look at sort of who was in that group, it's a bit of a who's who of people who really think through this and know the evidence really well. And they've done this amazing job of sort of narrowing the data into sort of what these sort of relevant and key evidence-based elements. So I think using that as a way to sort of determine what data you want to have, and then maybe you can even use the Shatterproof and maybe add some of your other items, or you might look at the Shatterproof and say, that's even probably still too much to keep track of. Maybe we need to reduce that some, and then have a way to regularly track that over time. And that's that how presented. Where I see a lot of these dashboards I think are really pretty neat is they'll have the item, they'll have like quarter 1, 2, or 3, or just the last 4 quarters, and then they'll have like a red circle if it's trending down, a yellow circle if it's sort of trending flat, and a green circle if it's trending up in a positive way, of course. And so, but the nice thing about the data is it gives you a way to sort of set policy. When I said policy, like start setting up these quality improvement projects. And again, the Shatterproof measures can do that. And I know with the Shatterproof measures that database is being accumulated. And as I'm talking to you, I'm talking as if it's all there. But even what you have there's some really good elements that's starting to build from there. And if you're in this webinar and you're like, oh, I really haven't had a chance to look at those measures, yeah, I'd certainly go to their website and look at those, because they're really good measures. This is and when you're doing sort of this data element piece, really think in terms of 2 types of data. One is this data you're tracking over time, whether it's admissions, no-shows, 30-day retention, dropout rates, what have you, these things that are really important that you're doing. And then also it's good to have in these dashboards, any quality improvement things you're working on. And these are sort of maybe temporary measures, things like, I know quite a few folks right now are trying to vaccinate their workforces. So, that's a quality improvement measure, is to increase vaccination rates. Another one we're working with quite a few people on is, it seems like as we're transitioning to the vaccination phase of COVID, the no-show rates are going up. As telehealth is being reduced, as people are, getting out and doing other things. And so, having those as sort of, different types of data. Within the Shatterproof, I'm just going to highlight a few the data categories and just sort of measures around them, and talk about potential other measures to consider. And so we'll, like the very first group of measures in Shatterproof is this improving access. Access to care is just so critical, critical to treatment outcomes. And so within the Shatterproof, you have same day and walk-in, and the TFS is the treatment facility survey, where there's just going to be a question on, on the survey for organizations to fill out, do you offer this? Do you have a plan for no inpatient or residential beds? And the patient survey, the PES, patient experience survey, they're asked, are you seen right away? And then, sort of classic measures that we've also seen around this is wait times and intake no-shows. Another set of measures is around, access to medications for opioid or alcohol use disorder. Here, within Shatterproof, they're looking at claims, also looking at retention and continuation. And that's one where we're quite a few of our improvement projects right now are around MOUD retention. A lot of concern about people using the medication once or twice and then discontinuing, or a week or two and discontinuing. And there's certainly some things that can be done to increase continuity. Medication availability, do you just offer it? And then a question that I'm really a measure that the more and more are looking at right now is penetration rates. For those who have opioid use disorder, how many are on medication, or what percentage? And right now, with people we're working with, we see a lot that are sort of in the 10 to 40% range. And you really want that to be over 50% because it's such a strong evidence-based practice. For medications for alcohol use disorders, we're seeing about 10 to 20% there. It's even lower. And that's another one that should be over 50%. And within your organization, if you don't know at this point sort of what your penetration rate is, or percentage use of this evidence-based practice, I'd suggest taking a look just to see, where it is. Another set of measures in Shatterproof is, use of recovery support personnel. It's turning out to be a really strong practice, a great engagement practice, and the evidence around use of peer recovery supports is mounting. So that's really good to see. With the treatment facility survey, there'll be questions around that. There's questions around it in the patient experience survey, and it's I think it's good. It's really it's becoming current and good practice. And so as you look at sort of this overall approach around these different elements, where there's also an opportunity is with these quality improvement projects, and that's where we really like this is where we do, frankly, a lot of our work. And so let's talk about that a little bit. So there's around the Shatterproof measures, there's sort of two types of quality improvement projects. One is I call programmatic changes, and here you want to implement something. Do you have peer recovery supports? Yes, no. Are you providing MOUD? Yes, no. Things like that. Do you offer mental health services? Yes, no. And then the other type of projects is continuous quality improvement. And those are, you're doing something and you want to do typically more of it. You want to do a higher percentage, you want to do it better, you want to offer more MOUD, you want to offer more peer recovery support services, you want the outcome part of the services to be greater. And so there's two types of projects. Let's talk about both here. First, around programmatic changes, there you want to use pilot tests quite a bit and try things out. You want to use these NIATx principles, which we're going to talk about here. But again, this is implementation. For those in the audience that are like very into, implementation science and like, this is it. You're trying to implement something. And, let's take MOUD. If you want to implement a new medication, like let's say you want to implement Sublocade, or right now we're doing a whole series of projects within jails, and a lot of the jails are providing only injectable naltrexone. I shouldn't say a lot, but a group are only providing injectable naltrexone, and a lot of those are wanting to do more and provide buprenorphine, particularly for people who are entering the jail settings already on regimen. And so for MOUD, for these sort of programmatic changes, what are things to think about as you're trying to implement something? As we've been doing MOUD implementation and improvement projects over, the past 10 years or so, we've sort of found like a bit of a cascade. And the cascade is, first you got to figure out a way to pay for it, and it could be through a grant, but ideally it's through reimbursement some way. And then, early on we're like, oh, there's a way to pay for it. We're good. We don't have to worry about anything else. And then we're looking around, it's like, wow, things are still not being implemented. And then we're like, oh yeah, you need a clinical champion too, particularly around buprenorphine, someone who can prescribe, which those guidelines, thank goodness, are starting to loosen up. But even without those with those guidelines loosening up, having a clinical champion who's really, particularly a physician, nurse, advanced nurse practitioner, like advancing this. And then once you have that, you're like, oh, good, we got a way to pay for it. We got a person to prescribe. And then you have to look at the workflow issues and really like, how are people going to get screened for it? How are people going to be put on regimen? Where's the medications going to be stored, and things like that. And you plan it, you want to review it. And then finally, once you got all that in place, you need the patients wanting to support it. And so you really need that feedback. So that's sort of these programmatic changes. For continuous improvement, here's our friend, the PSA Cycles, and really looking at ways to improve things. And within that, like for MOUD, a lot of our continuous improvement projects right now, as I mentioned earlier, are around MOUD adherence and really keeping people on regimen. The evidence says that people ideally are on regimen, MOUD regimen, for at least 6 months for it to have consistently good clinical outcomes. So we're really that's our goal, is to keep people on for 6 months. I think some of the average adherence rates we're seeing in a lot of places we're working with are below 30 days right now, and so there's lots of opportunity for improvement, and it is possible. What we use for these continuous improvement projects is this is what we call the NIATx model. It's something we developed about 20 years ago, and with it there's about 40 papers published on this right now in peer-reviewed publications. So it does have a strong evidence base, and the principles in it are evidence-based. And so let's talk about these some. And so what that means is for these 5-6 principles, I added one, for this, just because we found it to be so important. For the 5 principles, all of them have an evidence base behind them. And so as you're doing any kind of project, to sort of any kind of improvement or change or implementation project, to sort of say, oh, okay, let's sort of compare it against these principles just to make sure we're giving us the best opportunity for success. The first one is focus on key problems. Here, having executive, they always say, hey, to be successful, you need executive support. Well, this is it. This is it. You do need executive support. You want things that keep the CEO up at night, so to speak, that the CEO or the executive director or whoever is going to be wanting to focus on and not forget about, and really do this in a way, sort of operationalize it, if you will, by assigning what we call an executive sponsor, someone who's going to really support and champion the project. I'm going to sort of buzz through this. The other evidence-based principle, the second of the 5, is the change leader. And the change leader is just really saying that you got someone assigned to the project that's going to keep it going, going to assemble the team, going to make sure things are happening. A lot of the work we do, we go into organizations, things aren't going along as much as well as we'd like, and yeah, sometimes it's executive support. Sometimes there's really not a person assigned to keep things going, and it's important that they're there to keep things going. They're not there to do everything. Just to be clear on that. The next principle is ideas from outside the organization. And really what was found here is organizations fall into this challenge where they keep trying to fix things with the same ideas, and they sort of get stuck that way. And so having new ideas from outside the organization, even outside the field, was sort of the original evidence base we found here. Since then, particularly if you look at a lot of the implementation science literature, external facilitation is also a very strong change variable. In other words, having an external coach or someone of that nature who can help bring in new ideas and help keep you on task. And then another piece of evidence that's emerging is around learning collaboratives, communities of practice. And those are certainly as helpful. They aren't as consistently proven as the external facilitation, but they often help, and they're often better than not, being part of one of those kind of projects. The fourth item, and this item is as strong as all the others combined, is just really looking at the customer needs. We're also finding family needs also, or significant others, and really making sure that the changes you're making are going to make things easier and better for the consumer, customer, client, whatever you call them, patient. And you don't have to do a lot here, but you do need their perspective. You can have conversations with current patients and clients. You can have focus groups. You can do this thing called a walkthrough that we encourage when there's more systematic issues that we're concerned about, where you can have someone come in and be someone who's coming in for services for the first time. You can be someone who comes in and wants MAT or MOUD. You can be someone who's transitioning between levels of care, but sort of getting that perspective is really important. And then the last, and certainly not least, is really doing these rapid cycle tests and pilot tests. There's 3 basic questions around there. What are you trying to accomplish? How will you know a change is an improvement? What changes can we test? And with that, there's sort of this model that tests all that, and then really just using these plan, do, study, acts. You plan a change, you try it, you study it, and then you sort of see how it works. And you often have to do that a number of times. And when you do, good things happen. It's just, it's just gives you sort of a a way to sort of check things and see what you're doing to improve. And really the evidence says, the NIATx model works. The evidence says, there's quite a few other sort of improvement-based models that work too. But what the evidence says is you do have some kind of model you follow, and there's data is part of it. And so I think, if you have something like that in your organizational setting, it's going to be beneficial for you. So those are the five elements. Again, the data piece is really important. I think that's something that needs to work through that. It's something that's really wonderful that Shatterproof has put together some good measures for us. Here, back to the MOUD or MAT, here's some different data, quality improvement data tracking kind of stuff we see around, urine drug screens, pill counts, around diversion kind of stuff, wait times. There's lots of stuff you can do. Don't overdo it. While data is important, don't let it be the primary focus. Improvement's the primary focus, but you need data to know whether or not you improved. So with that in mind, just in summary, sort of think and, use this sort of Shatterproof experience to, sort of think about your quality improvement infrastructure. What kind of data are you tracking regularly? Who's sort of overseeing that, and what are you doing around quality improvement projects? And to provide a sort of an example of how this infrastructure plays out in practice is Lisa Blanchard is going to talk about what they've been doing at Spectrum Health Services. And after Lisa talks, we will have time available for question and answer.
Todd, so I'll go ahead and share my screen. All right, so I'm going to build on all of the great information you just heard from Todd on kind of the background of the NIATx model and how it fits in with the Shatterproof principles, and just give that bit of a provider perspective, right? What does that mean, for the providers that are in the room? How do we really apply this? And so, providers have specific quality improvement needs, and Todd already described a lot of them, but, from a provider perspective, we really have to make sure that we're in compliance, right? We have to make sure we have alignment with all of the regulations. In the description, when I was introduced, you may have noted that Spectrum runs 15 outpatient sites, and those are predominantly opiate treatment programs. And I like to kind of remind people that opiate treatment programs are probably the most regulated service that exists in substance use treatment, but maybe in any kind of treatment, right? It's significantly highly regulated. It's a lot of regulations we have to adhere to. But we also have accreditation, and then we layer in payer requirements. I'll talk a little bit today about kind of how to include kind of, payment transformation and different payment models that are starting to evolve in this process. We have to be able to document outcomes, and that's something that often is challenging, for substance use. We know the chronic, relapsing nature of addiction. We know how, how challenging it is to show, outcomes. And so things that, really lend themselves well to kind of, this kind of quality improvement and process improvement are time in treatment, retention, transitions in treatment. Those are really, positive outcome measures, integration of medications into treatment and retention on those medications, in a complex care environment. And you want to build on the strengths, right? We all are doing this work because we really care, right? We're all doing this work because we're called to it for some reason. And that's a really significant strength. And so we all want to move in this direction of improving our care and improving the lives of the individuals that we care about. And I think nothing kind of shows that more than this past year and a couple months now, where we as a field had to immediately shift to a telehealth model, right, in order to stay connected to people. That's a significant strength. And so our organizations have strength, our staff have strength, and our patients have strength. And we have to prepare ourselves to the fact that the healthcare landscape is changing, not just because of the pandemic, although certainly that has had impact, but the payment models, the way that we are approaching care and integrated care is really changing. And our patients are changing. I've been doing this work for, actually been at Spectrum for 22 years now. And the differences even in our patient population has really been significant, right? We know that there's significant differences in what's available for substances of use in the community, and that what's available really does drive use patterns. And we have to change our services to really adjust to that over time, and process improvement is a way for us to do that. And we need a structure that's easy, right? We're busy trying to save lives every day. And so having a simple, easy to implement structure to make those improvements that are sustainable over time. And so, using the NIATx model really does do that. So you heard Todd describe, that PDSA, the 5 key principles, and how simple that is, right? That really is helpful for providers to actually implement the model. Often quality improvement committees can sit around for 6 months planning what they're going to work on next, over analyzing data, take another 6 months to think about what big, huge change they want to make, and then another 6 months to review that and think about how much would have changed in the past year and a half for us if our quality improvement committees were really just making those big overarching changes. We had to kind of make some rapid changes in the last year and a half. And we as an organization at Spectrum have done quite a bit of that using the NIATx model. But we do take our existing quality improvement committee, we do track kind of overall data, whether that's, patient satisfaction, stakeholder, surveys, staff satisfaction, retention, show rates, kind of overall data, as I'm sure many of you do. And we have a quality improvement plan, right? We do that because we're dedicated to quality, but also because we kind of have to have a quality improvement plan for accreditation and licensing. But what we do is we actually take that plan and we make specific programmatic changes using the NIATx model that are going to work towards those goals, right? So it's not like the whole organization is going to shift this. We want to work on retention, and this outpatient site is going to try this process, and use the NIATx model and track data. And then everybody gets to learn from the things that worked and the things that didn't work. And we utilize really, detailed change teams at our sites that include the frontline staff. It can't just be, VPs of clinical and quality improvement directors kind of driving those changes. We need to hear from the clinicians on the front lines who are trying to do these telehealth sessions, the administrative staff, the nurses who might be administering medication and seeing patients day in, day out, to inform what process changes we might want to make. And we carry out the change projects and do that rapid cycle testing. And as Todd said, it might take, several different cycles to even see a significant change. And then we communicate that result back to the QI committee, right? Back to leadership, and update those results on the QI plan. So it's really very cyclical. And so we have been using Spectrum for a while. So I've been a NIATx coach for over 10 years. And that was kind of, shortly after I was introduced to the model as a treatment provider. And we kind of grabbed hold to how simple the model was to implement. But we've really done that to improve processes that are really often directly related to quality of care and really often aligned with the Shatterproof measures, right, that are on your treatment facility survey, that are public facing to potential, patients that might be looking for your services or family members looking for your services. And so some examples of that are fast access to treatment, right? So we've done change projects on implementing and improving, right? So those two different kind of options that Todd presented on kind of making programmatic changes, kind of putting in a same-day admission, walk-in admission model. And then we've used the model to actually further refine it, right? Make small process changes to ensure that we weren't losing people. You know, just moving to a walk-in service and saying that's it sometimes doesn't solve all of those challenges. And long-term treatment and follow-up. So we really have done a lot of change projects. So we run, you know, both inpatient and outpatient services at Spectrum, and we focus on kind of increasing that continuation in care, kind of post that acute treatment. You know, so keeping people connected when they leave, you know, an ATS or withdrawal management program, keeping people moving into our outpatient or connecting to a stabilization bed or a residential bed. And then when they're in outpatient, keeping people connected to care longer and really increasing our retention rates and reducing our dropout rates. And then, of course, we've talked a lot today about access to medications for opioid or alcohol use disorder. And so that's kind of that increasing that initiation and engagement, right? Which is often kind of a measure that payers will measure us on. How many people are we starting on medications once they've been diagnosed with a opiate use disorder, and how many kind of stay on those medications? You know, and we've done that with trying to connect individuals directly from inpatient settings or residential settings onto medication before they even leave, so that they're ready to continue in outpatient. And those additional services to support recovery, you know, really looking at ways to increase family engagement in care and doing really targeted NIATx projects on that. And then just again, that outcome. So, you know, implementation of an outcome measurement tool. So, you know, I said earlier, it's challenging for us as substance use treatment providers to show outcomes because we know that that's not a black and white response, right? So there is an element of reducing harm. You know, all of the work we do is reducing harm, you know, and it's not like, did somebody enter, like, it's not a yes or no, it's not a linear path to enter long-term recovery. And so any ways that we can measure outcomes to, you know, assess our own treatment effectiveness will really help us, you know, continuously improve the quality. And so I mentioned, you know, kind of in the what providers need, kind of meeting some payer requirements, and that there are some shifts in the healthcare landscape. And so, you know, many of us, you know or, you know, are aware that there have been significant shifts, you know, both, you know, nationally and at local levels on what healthcare looks like, right? How we deliver healthcare, how we deliver behavioral health, how we, you know, pay for services. You know, we're really all focused on trying to provide better care that maybe doesn't cost as much, right? Keeping people out of emergency departments or out of acute care and inpatient care, you know, both for medical or behavioral health or substance use treatment. You know, and those things kind of move in the same direction as helping the patient, right? So if we can keep people connected in community services, they're doing better, right? If they need less emergency room visits, if they need less hospitalizations, they're doing better, and they actually cost the system less, right? So those two things move in the same direction. And so in order to really keep a focus on that way of approaching healthcare differently, moving from episodic care, being paid for discrete episodes, being paid for volume, we really need to be able to work with payers and develop value-based care models. And in order to do that, we need tools, right? We need to be able to monitor how we're doing. We need to be able to kind of ask data questions about, you know, are we meeting those goals maybe of keeping individuals kind of out of acute care and keeping them in community care? Are people staying in treatment longer? Are we improving our initiation and engagement, you know, of medications for opiate and alcohol use disorder? So an example of this, you know, I did, you know, vet this with Tufts first. You know, we at Spectrum have partnered with Tufts Health Plan to establish a Center of Innovation program. And that's really a partnership of the provider on the front end, right, and the payer on the back end, looking at how we can work together to just slightly shift our services to improve outcomes, right? To make things just a little bit differently, you know, recognizing that kind of doing the same thing you've always done, you'll get the results that you've always gotten. And so we're piloting and using kind of our NIATx approach as an organization, you know, new approaches to care, right? Tracking, you know, how we refer to maybe, you know, new care management platforms or recovery coaches, you know, different services, and how individuals do when they are connected to those services. And we're even using kind of our NIATx approach to pilot the use of a digital therapeutic, right? You know, we're all doing this webinar now virtually, especially in the past year and a half. Kind of, you know, a kind of electronic means of connecting with folks has been a really big you know, part of all of our lives, and even as this pandemic shifts, that's not going away. And so there is, you know, an opportunity there. And so we're actually piloting the use of an FDA authorized therapeutic done by Pear Therapeutics called Reset-O. And we don't know how it's going to work, right? We know that there's evidence-based for that therapeutic, that there have been studies that have been done, but we don't know how it's going to work for our patients, right? In our programs. And so we're really using this NIATx approach to try it out, right? To learn from it and do that in combination with Tufts, right? Tufts is kind of using their partnership with Spectrum to learn whether this is something helpful. And so we'll all benefit from using that model. But really these partnerships, like what we're doing with Tufts, are going to change how providers approach payment, and how providers can really use this kind of pilot test approach, you know, this process improvement approach to drive, you know, data-driven kind of clinical outcomes. And we find as an organization that the NIATx model, you know, really helps us with some of these big shifts, right? That feels really big, but if we pilot test for one location for a small number of patients, you know, a new, you know, digital therapeutic, for example, that doesn't seem as heavy, right? It doesn't seem like as big of a lift of changing our whole model of care. And that's exactly what we're doing, is working towards that incremental change. And so, you know, I mentioned we've been doing this for a long time, you know, and I think it's probably helpful to Spectrum, you know, having me there as a NIATx coach, but we've done a ton of change projects over the years. And so I just took a quick sampling just so folks can get a sense of what are the kinds of ways in which we have leveraged this process improvement model to make changes. And so some of these are kind of older changes and some of them are a lot more recent. And so we've reduced wait time from our intake to our first counseling session from 28 days to 7 days. You know, a huge shift, but that was with multiple cycles moving us in that direction. You know, we've piloted the use of contingency management, which that's a tough one sometimes for providers to implement because it costs money, right? Like, and we don't have a ton of money of substance use treatment providers, but we piloted it like in a small scale with some really high risk patients, and we saw results, right? So we saw an increase in negative toxicology screens as one of the measures of how an individual's progressing in care, and improved attendance. And one of the things we consistently find with the use of contingency management is that the attendance and the subsequent billing, you know, again, those things move in the same direction. Patients get the care that they need. We get paid, like no shows don't help anyone, actually more than cover the cost of any, you know, raffles, gift cards, you know, bus passes, whatever it might be that we are using. And we've improved that same day admissions process. So I mentioned that already, that we have implemented widespread across all of our outpatients, kind of walk-in same day access for, you know, medications for opiate use disorder. But we still found we were losing people, right? We were losing people by the end of the day, by the end of 3 hours. And it really spoke to kind of needing some process change on how exactly we did immediate access so that we, you know, kept people for that whole day to that end point where they received their first dose of medication. And of course, increasing attendance in group sessions with lots of incentives, lots and lots of projects. But more recently, in this, you know, landscape that we have of telehealth and trying to stay connected to really high risk folks, is we are piloting a drop-in group right? So for those that aren't showing up to things, we said, well, why don't we try this new model? And we've had great success. And so the benefit to that is that other sites, like, we've piloted at one location for a small group of patients, and now kind of all 15 of our outpatient sites are starting to implement drop-in groups because they've been so effective. And we've done similar changes with our inpatient programs. And this is that kind of continuation of care. And so we've increased referrals from our inpatient to our outpatient in one change project from 5 per week to 22 per week. We did that predominantly with cheat sheets, right? Things that were really simple to implement. And so, some really data-driven results there. Really focused on increasing the transitions from our level 3.7 detoxification, withdrawal management unit to our residential for appropriate patients. And again, that the recovery supports increasing the frequency and type of support that we offer families in our inpatient settings, and piloting kind of our outcomes tool to review treatment effectiveness. And lots and lots and lots of other projects that we have done. And so that's kind of our example of how we've leveraged NIATx kind of over the years, both for future-oriented kind of healthcare development, but also just, how we make changes as an organization. This is kind of how we solve challenges, is we start a change team. And it also, really helps our staff feel less, burned out, because they know they have somewhere that they can at least try to make changes. And so with that, I'll kind of turn it back over to, to Todd and the group, and we've got, a good amount of time to do some, focused questions.
Thanks so much, Lisa. Appreciate it. And Todd, thank you for your talk as well. Right now, you'll see a poll question come up. So we can take a minute and address that or answer that. And the question is, does your organization have a quality improvement committee? So feel free to respond, and we can discuss the answers. And while folks are doing that, I did see a number of questions come in through the chat, which we'll get to in just a few minutes. In the meantime, if you have additional questions, feel free to enter them in the chat, and we'll answer them in just a few quick minutes. All right, we'll give another quick minute for the poll, and we'll end it. All right, so we can see here that of those that responded, 86% have a organization that has a quality improvement committee. Great to hear. Todd, anything that you want to add based on those responses?
No, that's really good to say. Really, I mean, and really, if you look at sort of that, setting up that infrastructure, that creates a great start.
Agreed. And I know we had a second poll question, which we can launch here.
Yeah, we're very interested in just where people are with MOUD. It's just so important as an evidence-based practice, and some pretty good evidence out there too that communities that have higher rates are having lower overdose deaths. So definitely an important public health issue.
All right, we'll go ahead and close the poll and display the results.
Yeah.
Interesting. Todd or Lisa, anything that you want to add, any insight you want to add on the poll results?
Yeah, I would add.
No, I think thanks. Go ahead, Lisa.
This is the Zoom challenge, right? So that that 41% with streamlining processes, it really screams for something like kind of using a model like NIATx, because that's exactly what they are, right? They're processes, and they're processes that we get to change, right? And we get to try out maybe if we did it slightly differently. And that can be, on how we deliver the medication. We've even done things around reducing lines for medication in our opiate treatment programs, right? Like, what are ways that we can change our process so that people aren't waiting as long, because nobody likes to wait. And then we lose people, right? And they might not receive their medication that day. Or if we're partnering with other organizations to provide medication, how do we kind of make that process more streamlined? And so it is because of the regulations, right? Sometimes, I often will say this, like sometimes it's the regulations that make it a little bit more challenging, but it doesn't mean that it's not possible. And there's lots of ways to kind of just shift the processes to just make it, less of a burden, so that there is more buy-in, and it is easier for, what are some really complex, high-risk patients to access the medications they need, on a regular basis.
Yeah. No, well said, Lisa. And I need just to add to that, just if you're having challenges around that, please don't ignore it, because it will it'll create problems as you might expect. So and it's good when we did this survey as recently as a year or two ago, that implementing new MOUD was much greater. So it's really good to see how far the field has advanced in a pretty short period of time. So something we should brag about. Should we go to some of the questions?
Yes, absolutely. Thank you, Todd. So the first question I see in the chat was from Anna, and she asked, can we please expound on penetration rates?
Yeah, that's a great question, and thank you for asking. If you statistically, what it means is the number of people who are, if you're doing a percentage, the number of people who are on MOUD divided by the number of people who are diagnosed with a current OUD. And so, what we find in programs is you'd think once MOUD starts, you'd be up at like 70, 80, 90%, but it's usually closer to 10, 20, 30%. And sometimes there's reasons for that, but I think to know that number and just sort of understand why is good. And I think it creates there's an opportunity there. Another number that's often associated with that is just what kind of patient loads do your prescribers have. There's a lot of people who've gotten their buprenorphine, their X waiver, who have 1 to 5 patients, and I'm not saying their whole practice should be that, but usually if there's low utilization of your waivered physicians, at least for the buprenorphine piece, you're probably not going to see as those higher penetration rates unless you have a really large medical staff. Good
point,
question.
Todd.
Yeah.
So I also saw a comment from Sarah mentioning that the 6 months MOUD average measure is a quality measure for programs, not an indication of how long people should be on MOUDs. She mentions numerous observational studies show that opioid overdose risks are elevated far beyond 6 months. And Todd, I saw that you commented on a chat. Anything you want to mention in addition?
Yeah. No, I mean, I'll say something. I'd be great to hear Lisa's perspective too, just with the OTP and like. I mean, yeah, as I said in the chat, OUD, AUD, alcohol use disorder, those are chronic conditions. And so with the 6 month, I think I see that more as a threshold. You want people on, the pharmacotherapy at least that long. But there's a number of people, or maybe most people, that need to be on it, forever. And what you don't want to do, and God, I wish I could pull out the study that I saw, where you don't want to have artificial stops. Like, hey, after a year, we're going to work on, titrating you off. Because that, the evidence there is not good. It really shows that a lot of relapse, a lot of overdoses and things like that happen when you have sort of these artificial stops. And I know there's still some payers out there that are creating that, but I'm seeing less and less of that. And I wouldn't institute your own. Because it doesn't follow the evidence base, and it creates a public health hazard.
Yeah, and I would just expand on that. That I think you're exactly right. I think your comment, Sarah, is on point. Right, that 6 month measure is a quality measure for programs, and it's there because if we can keep people connected and on continuous medication for 6 months, then that's kind of the minimum, right? That's kind of the floor. And if we can keep them connected for 6 months, we can keep you connected for 8 months, for a year. And then some of the literature suggests that it's most effective to actually be on medications for at least 2 years, in order to get kind of a full effect. But it's so individualized, right? Some people are going to need it long term, right? There's lots of complicating factors. And they might, not need to be on that particular medication, or could change medications, and having that flexibility to change your treatment plan for what makes sense for the patient, but not to, for example, as Todd described well, having these kind of artificial kind of timeframes or stops, but have it be very individualized based on what that patient wants, right? So that patient-centeredness, which is very central to the NIATx principles as well, what they're willing to do, and what makes sense for that person. And that could be, very long-term, but most evidence shows at least 2 years, especially now, right? And, the risk of the pandemic, even, we're seeing overdose risks climb, both from the isolation of the pandemic, but also, the advent of fentanyl, and how high risk it is, and the likelihood of return to use, it really is a support for keeping individuals connected to medications for the long term.
And Lisa, that's a good point. And I was actually going to just ask as a follow-up, based on everything that we're seeing, say, in the last year plus, especially with COVID and changes with the introduction of fentanyl, do we see any of these measures moving? So to say, 6 months is just the average measure, but as you mentioned, there is literature that says it can be up to 2 years. But do we see like that 6 month mark increasing?
Yeah, I mean, just qualitatively, just from my own experience as a provider, it's very few people who are stabilized at the 6 month mark. And I think that has a lot to do with, the complex needs, complex trauma, co-occurring, mental health, medical conditions, but definitely fentanyl, in the substances that are available that really do kind of drive use patterns that, it's much less frequent that we qualitatively see in our treatment programs that someone can be kind of stabilized, and especially stabilized and tapered, within a 6 month period. Even if for regulatory reasons, we might need to start someone on, for example, in methadone treatment, if they need to start on a kind of detoxification protocol because they don't have the treatment history or other regulatory needs to be on a maintenance protocol, we're almost kind of unilaterally, having to do a waiver to extend that, either extend the detoxification timeframe or move someone to maintenance, because we're just not seeing folks stabilizing in that amount of time.
Yep, and that makes sense. There's much more research that's been done for other chronic conditions, and yeah, sometimes people can start on pharmacotherapies for blood pressure or even diabetes, and through lifestyle can get off them. But most people, once they're on, and so I think we're going to find a similar situation here, based on what Lisa's observing and what the initial research is saying.
Oh, that's interesting. Thanks for clarifying that. Next question in the chat was from Helen, and she says she would love to hear some examples of good outcome measures.
And so I'll just give the example of the one we're piloting, just as an example, but not saying kind of it's the one. But the one that we are kind of piloting, and this is where process improvement really comes in, right? Because an outcome measure is only as good as how often you're able to administer it. And so that's what we're really using process improvement to improve upon. We're starting it in our inpatient settings as we are piloting the use of the treatment effectiveness assessment, the TIA, and because it's built on the SAMHSA domains of wellness. So that's in line with a lot of our clinical programming, and it's short. It's just how do you rate your life upon admission, or at various points in these domains, and we hope that gets better, right? And so that's just what we're piloting. I know it's been normed and has some evidence base to it, but there isn't a lot out there that's really focused specifically on substance use treatment. In previous outcome tools that we've tried as an organization, may have they didn't have enough of kind of a assessment of the actual substance use treatment. So that's kind of why we're piloting this one, to see if it meets our needs a little bit better.
And with that pilot, I assume you're doing that as long as they're engaged in services, and then past services, you really don't have a way to collect data practically.
Yeah, we're trying, but that's one of the things we're having a challenge with, right? Which is we're piloting it in our inpatient programs, and that's just a real challenge in inpatient care, is that once they leave your four walls, it can be really challenging to stay connected. And so that's, obviously part of why we have a lot of projects focused on keeping people within care, in our system or outside, just in care in general. But even staying connected, it's just hard it's harder for us to get a kind of post-discharge, a TIA done than it is to get one done upon admission and before they leave.
Yeah. Yeah. And I mean, I think for outcomes, first of all, to have something during care, I think is good. Especially an outpatient where the length of stays are going to be longer too. So that's one item. And then post-care, I think any kind of data you can get that's somewhat reliable is good, because it's, you're not resourced to collect that data. And some states, like Kentucky and Iowa, they have a third party collecting that kind of data, and that's really, really helpful. And then the other, we can sort of use the Shatterproof measures, and with Shatterproof, they do something that we call sort of proxy outcomes. And so we have, SUD related hospitalizations, you have ED visits that come out of claims data. Some people look at readmissions. Lisa, I'm sure you guys probably look at some variant of that for your residential. And so some of that you can do. And then, in the Shatterproof 2, there's a couple patient measures that they can give you some feedback to. But I have to say, in short, whoever asked that, thank you for asking, because it's an area we need to get better at, and I think just for people like us to talk about it, and people like Lisa to pilot it, and people like Shatterproof to start including it in their data sets is exactly what's needed.
Great. I do want to keep us moving down the questions in the interest of time. I see another question from Sakina. I hope I'm pronouncing your name correctly. And the question is, was the drop in project conducted during the pandemic?
Yeah, I just got that change project kind of, update last week, right? So this was specifically piloted because of how challenging it's been to engage individuals during the pandemic. It was in our largest opiate treatment program in Central Mass. And we have about 1,500 patients there, and we're asking people to come less, right? So we've got a little bit of a relaxation of regulations during this public health emergency, where people have more take homes, and that's wonderful, right? People can stay connected to care. It's reducing barriers to staying in medication treatment, right? It's all good things. But some of the kind of natural kind of engagement strategies that an opiate treatment provider might use, like when you come in to receive your medication, I'm going to ask that you see your counselor. I'm going to ask that you go to your group, and then you can have your medication right after that meeting because we really care about you. Are harder to do when they're coming in less, right? It's just a lot harder to do, and so we've definitely seen some challenges at times with, especially as the telehealth kind of wears on people, right? I'm sure we all, like, I'm wearing my blue light glasses because I'm standing in front of a screen all day. We all are getting a little bit of a Zoom fatigue, and our patients are no exception to that. So we've seen kind of drop-offs from what was kind of even some increases in engagement in counseling because of reducing the barriers for telehealth, that I can just, call you, do a video session like on my lunch break, or I don't have to, get childcare, leave work, all of those things. We're starting to see a drop off, so that this is how we kind of address challenges, right, in our organization. So the program did a NIATx change team, and they created this kind of drop-in option, right, like that. And we've actually seen a lot of initial success with folks who hadn't been showing up to groups for a period of time. And we're worried about everybody right now because return to use rates are so high, even if we've got, long-term, abstinence. And so we really, are worried of trying to stay connected to everybody in our care. And it's been really helpful to actually see more people. So, we're going to be kind of spreading that, across all of our outpatients.
Excellent. Perfect. Another question, let's see, from Helen. What kind of contingencies, you said raffles, bus passes, I would like to hear more about this. And she mentioned same for piloting outcome measures. Any specifics about measures and tools you used? Any nuts and bolts thoughts would be, I think you maybe say helpful at the end.
Great. So we just talked a little bit about the outcome measures already. So I described what we were piloting there, but yeah, we do a lot of contingency management, and it varies. And often we'll ask the patients what would be most helpful for you, right? So that goes back to that NIATx principle of kind of understanding and involving the customer, and it definitely varies. So one of the most interesting contingency management kind of rewards that we've used that's actually been one of the most effective is in our busiest programs, like for example, that program in Central Mass with 1,500 patients. We've got 6 dispensing windows open from 5:30 a.m. to 5:30 p.m. But no matter what you do, there's going to be times when you kind of come in and there's a line, right? Nobody likes to wait. And so we've done contingencies. If you make it to your groups, right, make it to your counseling, you can earn a fast pass, right? So we borrowed that from Disney, right? So to borrow ideas from outside your organization, and that, if anybody's been to Disney and you do it without a fast pass, like, you are not happy, right? Especially if it's hot and you've got a 3-year-old, like, it's no good. And so we borrowed that idea, right? And so you get a fast pass to the front of the line and you receive your medication, you can get out the door and on with your life. And that's been the most effective. But in smaller sites where there's, there is no lines, for example, then that's much more of like the, Dunkin' Donuts. Sometimes we say, Spectrum runs on Dunkin's, or, Stop and Shop, or bus passes, kind of, we give people options on what they would like to kind of earn. And we've been part of a recent project on increasing access to contingency management. And we've even done things we didn't do before with just kind of having like a prize cabinet, like with like just kind of more like inexpensive prizes, and for some folks, they really like that, and it's really been effective. So it kind of runs the gamut.
That's great to hear. And as someone who is from New England originally, I love hearing those New England brands. It takes me home. So and you mentioned, Lisa, a little bit about smaller organizations. So Sakina asked another question, and she says QI teams are difficult to manage in very small organizations with one QI person on board. Can you speak to sort of how some of the challenges that are there in a smaller organization and some strategies around maybe overcoming those in a smaller setting?
I mean, I can speak to my experience, and Todd, if you can feel free to jump in. What I factually find is the use of the NIATx model takes the load off of the quality improvement committee, right? So if you've got a quality improvement committee of one, and actually as an organization our size, we've been in a similar situation, you know, it really kind of brings it to the front line, right? To like the people that are actually, you know, using these processes that probably have, you know, I always say like they probably have way better feedback than I do on what might want to change. Like I'm not going to have the best idea. And I think QI directors kind of can be similar in that way. And so the, you know, kind of QI person of one might provide some structure, might share some data, might kind of do some of the overall information, but it's the site-based, you know, change team with representation from the frontline staff and all the multidisciplinary teams that are trying, like that are creating kind of, you know, ideas for the change team and are, you know, trying them out. And so in some ways, I think it can actually really help.
Yeah, yeah, and I think the QI process is more important than the team. And I, you know, be careful with that. I mean, it's good to have a team, but you're right. If you're in a smaller setting and having a team get together to talk about something means shutting the whole clinic down. Yeah, that's not going to work, right? And so I think, you know, having a, you know, sort of a change leader type who's keeping projects going can you know, can keep the projects going in ways to sort of get over not having to shut the whole clinic down, is, you know, have teams integrated into any kind of like, you know, any kind of, you know, ongoing committee meetings you have, or if you have like an all staff kind of meeting, just integrated into that. Before the day starts, clinics, primary care clinics use this a lot, the notion of huddles. And the important thing with a huddle is do it standing up. And it's amazing when people are standing around for a meeting, they get so much more efficient than when you're sitting around you know, a board table or just a, you know, a meeting table somewhere. And so, yeah, find ways to integrate the process into the operations, and not, you know, try to not have, you know, having a team that meets once a week for an hour or a half hour or whatever be the limiter.
I think that's a great suggestion, and even my puppy in the background thinks that's a great suggestion. I apologize for the background noise. A couple other comments here. Ford mentions, keep in mind for opioids, the FDA approved medications for OUD are only approved for opioid dependence. Thanks for mentioning that, Ford. Robert, oh, no worries on the poll. Let's see. Ford, another comment says, yes, for those that need MOUD, at least a year is better. The 6-month time frame is simply a measure specification for several continuity measures. Thanks for mentioning that, Ford. And Helen mentioned they might suggest cigarettes.
I can actually tell a NIATx related story that includes kind of access to cigarettes. So yeah, I mentioned our walk-in admission process for our opiate treatment programs, and losing people, even though it's happening in one day, right? All you have to do is show up. We'll take care of your biopsychosocial, your screening, you know, your medical screening, toxicology screening, and you see the physician or mid-level waivered practitioner, and you receive your first dose. Like, what could be easier than that? And we actually found we found lots of things that we did a walkthrough, and you know, we found a lot of things that we could change around, you know, duplicate questions and how long things could take. But one of the things that we weren't expecting to find is that some people were actually leaving because, you know, we have some really strict regulations, by licensing that don't allow us to kind of have smoke areas or have, smoking kind of be kind of on or near the building, right? Like hospitals, like, you can't be on or near the building. And we were actually losing people because it was a long process, just because it does take that long and people needed to go have a cigarette. And so we had to actually kind of just find creative ways to make sure that that would happen, because I'd much rather you smoke a cigarette and get started on your medication than leave for that reason, right? Like, so you're absolutely right, Helen. Like, so that might be the reward that some folks might choose.
Yeah, it sort of creates that balance of cigarettes and vaping versus other kind of, gets into some harm reduction kind of conversations. But yeah, I think we have to sort of weigh the public health risk there for sure.
That's a good point. Those are all the questions I see in the chat. If anyone else has any questions, feel free to enter them in. And while we wait for that, a couple of just last minute housekeeping items. Our next CQI webinar will be on June 24th at 1 p.m. Eastern time. Stay tuned for an invitation in the coming days. And also I know we have lots of providers on the call, did want to just sort of enter in a commercial for our treatment facility survey that is now open. It opened on May 5th. If you have any questions in Delaware, West Virginia, or Massachusetts, you can contact myself at abutar@shatterproof.org. Or for New York, you can contact Leah Kaufman as well. So just wanted to put that out there. We are excited about the next round of data collection for the survey. So please fill out your.
Ankit, could I just jump in to clarify quickly?
Oh, please, Carolyn.
Yes, and to note that the treatment facility survey, as Ankit said, is only open in 4 states right now. So if you are a Louisiana or North Carolina provider, that will be happening later this year. So do not worry, you did not miss an email. Just want to clear that up. So just Delaware, just Delaware, New York, Massachusetts, and West Virginia right now. So you will not have received the survey if you're in Louisiana or North Carolina, and that's not an issue.
Yeah, thanks, Carolyn. Just those 4 states for now, correct. Any other questions? I don't see anything else in the chat. Feel free to unmute yourself and ask. All right, well, if there are no other questions, we can give back a few minutes of time. Thank you again to Lisa Blanchard and Todd Molfenter. I really appreciate your time and the context you provided. Thank you again, and hope you all have a great rest of your day.